LCBN television broadcasts 24/7 on UK Freeview Channel 271, Roku TV, Amazon Fire TV, Android TV, Apple TV, Google TV, See Love World, LCBNTV.com, LifeComTV.com.
Good evening and welcome to another episode of Conversations with Lydia. My name is Lydia Khalil. Today I have two ladies who work in the medical field. We are going to talk about children, we're going to talk about diagnosis, we're going to talk about medication. Those are quite big things when we are talking and thinking about children. Nobody expects that their child is going to be diagnosed, if anything, a mental condition. And not only that, and that the medical condition is something that we can't manage at home. We need professionals to help us manage the medication. And in some cases, it might be a lifetime diagnosis. So if you will help me welcome Ms. Osifo. Good evening, please welcome. And Yetty Iriah. Good evening.
Hi, everybody.
Hi.
Good evening, and thank you, Lydia.
You're welcome. Thank you for both for agreeing to come today to talk about something that is actually quite a sensitive area, but I feel quite passionately about it. It's something that I know it's challenging work. It's challenging work for you, and even more difficult for children. So I'm going to sort of read a little bit about both of you, and then I'll ask you to talk a little bit about yourselves, and then we'll go into talking about the work that you do. Okay. Liz is a senior nurse practitioner and a lead clinical nurse specialist in the field of adult and children mental health. She works as a lead nurse with the NHS. She's passionate about changing the narratives of children with positive outcomes, supporting children, adolescents, and their families as they go through mental health challenges. She's trained in the dialectic behavior therapy, equipping children and young people with skills to regulate their emotions, behaviors, and empowering them to maximize their potential. As you can see, I read a lot about the people that I bring on. I ask them all to send bios, just to show that these are our people from our backgrounds who are working actually as professionals in various fields. So I'm going to read Yetty's own now. Dr. Yetty Iriah is a consultant, child and adolescent psychiatrist. She works as a consultant with the NHS, and she has a special interest in autism. Yetty is passionate about supporting young people and children, as well as their families, as they navigate their challenges, as she's written, navigate through their often difficult journey with mental health. Thank you both, ladies. I'm not going to read the other bits that you do yet, because I want us to sort of concentrate on children diagnosis and medication for this part, and then the next part we will talk about the other things that you do. So Liz, do you want to share a little bit about yourself personally, what you do, what you enjoy, your journey into actually becoming a nurse, and why you chose mental health and why children?
So I guess my journey with mental health started way back in 1994. And I guess why I set off on that journey in the first place was the fact that I've always had a passion for the mind and the things that go on in the mind. As the good book from Rick Warren says about the battlefield of the mind. So there's always been that intrigue for me as to, what goes on in the mind and how do we heal the mind.
Mhm.
So this was what pushed me into nursing and then into that field of mental health. I guess if I was asking any of my mental health colleagues, a lot of us would say about the job satisfaction and also contributing to society, helping to alleviate distress for families and helping them navigate their journeys. And the reward at the end of it for us is seeing families go through their journey and come out the other side of things. And the part of mental health that I've soldiered on since is I get fulfillment and joy from the fact that there's never 2 days that are the same.
Mhm.
There are different challenges that come through each day that you learn from, you can reflect on, and things just keep giving and unfolding as you go on every day. And over the course of my career in mental health, I've worked both. I did my first 19 years in adult mental health services, where I worked both as a clinician and also managed services within adult mental health. Going through and looking after people with severe and enduring mental health difficulties. And more recently, I've done work with children and young people and their families as a lead nurse within the NHS service. So I guess on the whole, it's about the satisfaction and the reward that I get personally as a human being, number one, and as a mother myself. Yes, from setting off on this journey and helping people navigate this journey for them to be able to create that life worth living for them.
Okay, because I from what I know, the people that you work with are really challenged with mental health. We're not talking sort of everyday stress or anxiety. These are people who need medication. Yeah.
Well, it depends. So depending on the presentation or what we call the nature and degree or severity of the illness, we go from mild presentations right up to the severe end of the spectrum. So we have different people coming through our doors, and my more recent work with children and young people. So we're talking about, from about age 5 or from age 0 sometimes to the age of 18.
Okay.
So, yeah.
Okay. Which is surprising because you don't expect that a child that is age 0 will have.
Well, the referrals can come through us, but we have services that work alongside us to cater. So we have the under 5 service within my service.
Yeah, no, but I think I was just saying how you wouldn't imagine a 5-year-old, for example, has those kind of challenges. That's where my point was actually going. That to imagine that a 5-year-old has mental distress, that can't be soothed at home, like with a lolly or a hug from mom or dad.
Okay. So I guess for us, when we look at this, we think more about the biopsychosocial theory, where when you look at, some of the etiology of what's going on for some of these families, be it genetics, the biological component, be it the psychological component or the social cultural component. So say a parent that has a 0 to 5-year-old notices something different from their child. The child is behaving oddly or in a bizarre way that maybe the older children that are in the family haven't had that presentation. And then that parent becomes concerned enough to say, oh, this is very unusual, out of character for this child. Maybe the child, say, if an example of a child that has, that is starting to show signs of a neurodevelopmental disorder. So the parent now, heads to the GP to say, I'm concerned about this child. They're not talking, they're not walking, there's something not quite fitting. What do you think I should do? And of course, you know, as we know, general practitioners are skilled in everything that they do, but they're not mental health specialists.
Yeah.
So the GP can then decide that, you know, I'm way out of my depth here. How about I get some consultation from the children and adolescent mental health services? And that's where those sort of referrals come through people like us.
Okay. All right. I will hold on to what you said about hormonal, biological, some of the stuff going on in the house, because those are the things that we will sort of bring out later. But I always celebrate nurses every time I go into a hospital, because I don't think it's a profession. I think it's a vocation. I always think, who wakes up and decides to be a nurse? Because it's such challenging.
Yeah.
Or I see it as challenging work. But what you're saying is actually I enjoy my work. I'm rewarded by seeing the change.
Yeah.
With people when
no doubt, you are right in what you're saying. I mean, personally, right through this 23 plus years, I've had friends even till today saying to me, you must have a screw loose in your head to be doing that field of work, which is true. But you know, each to their own. And what I always say to friends is, apart from obviously the rewarding bit of it for me, it's also the fact that somebody has to do this job, you know, and I happen to be one of those people willing to do it.
Okay, so we say thank you. Thank you on behalf of the rest of us who can't imagine why somebody would decide. I really celebrate nurses, because I'm always like in awe of the work that you do. And I'm not just saying it because you're you're here today on the program, but just every time I go to a hospital, I'm like, these people, I don't understand why they make this choice, but hearing from you is good. We're going to ask our consultant, Dr. Yetty, now. Hi, Yetty. I know you've been
Hi, Lydia.
listening to us talk a little bit about your world as well, or quite a lot about your world. I'm actually quite curious, because we talked a little bit about this before we came on air, about how does a child get diagnosed, you know, with some mental distress or mental illness, or sort of a late developer. Now we get to know what's wrong with the child. How does that happen?
Okay, so first of all, thank you for having me on today. How does a child...
Dr. Yetty now. Hi, Yetty. I know you've been listening to us talk a little bit about your world as well, or quite a lot about your world. I'm actually quite curious, because we talked a little bit about this before we came on air, about how does a child get diagnosed, you know, with some mental distress or mental illness, or sort of a late developer. Now we get to know what's wrong with the child. How does that happen?
Okay, so first of all, thank you for having me on today. How does a child get diagnosed with a mental illness? That's quite a huge question, and you can talk about it from different angles. But essentially, children, like I always would say, are the barometer for what's happening in their environment.
Okay.
So if we look at the biopsychosocial, theory, like Liz mentioned, there are different reasons why a child may have a mental illness. Now, there are what we call neurodevelopmental disorders. So neuro means having to do with the brain, and developmental means, that the child is born with it. So there are neurodevelopmental disorders that children are actually born with. But then they present at different ages, okay? So at the time the child is born, most people, it's a happy time, it's a new baby, everyone is excited. And maybe somewhere down the line, few months or few years, then, they start presenting with some unusual behavior or unusual symptoms, and most parents then notice that something is wrong. Now, at the time that happens, at least, I want to talk from the point of view of the United Kingdom, because that's where we are.
Yeah.
So most parents, their first go-to place would be the GP. So GP is primary care, and the GP will do their own kind of assessments, preliminary assessments, and then they would need to make a referral to people like me, and then we would then be thinking about doing an assessment and looking for whether there's a diagnosis, and then considering what intervention. So yes, children from any age can present with what we would consider a mental health challenge or a mental health difficulty. Now, from if it's a neurodevelopmental disorder, they're likely to present quite early on in their life. If it's emotional, if it's psychological or social, they may also present at any time. But then we have different age groups have their different kind of unique difficulties.
So give me an example. This is not only, some of it is new to me, and some of it are new to others that are watching. What kind of diagnosis can people, I know obviously if there's something wrong, I know this is how children with autism get diagnosed.
Yes.
But if it's not autism, what else could it be? Just I'm not saying that's the range.
Yes.
All have an idea.
For example, So for example, people would say to me, how come you would say that a 5-year-old is possibly depressed? Now, a 5-year-old is not expressive yet in their language, is not emotionally expressive, but they may present with symptoms of depression in their behavior. So, for example, a 5-year-old who's been dry, who's been, dry for so many years, just suddenly starts wetting the bed, or just suddenly starts being, throwing temper tantrums, being aggressive, being temperamental. Then that is, at that point, the parents may then become quite worried, because this is an unusual behavior, this is an unusual development, and they may not at that time, recognize it as a possible sign of a mental illness. So they may feel, okay, they go to the GP, this child has been bedwetting for the last 3 weeks. The GP will be concerned as to, does this child have a urinary tract infection? Do blood tests, do a urine dipstick just to see if there's an infection, and it comes out negative. And then they look at the behavior, what's happening at school, what's happening in the nursery, what's happening at home. And then, after excluding different variables, they would now do a referral to the Child and Adolescent Mental Health Service. So that's in a 5-year-old. Now, let's look at a teenage girl, for example, who then suddenly is not seems to be withdrawn, keeping to herself, not eating, losing weight, possibly not sleeping, having difficulty concentrating at school, and there's general lack of motivation. These are all symptoms of a depressive illness. Now, the first port of call again would be the GP. The GP will look at things. What's happening in the family? Has there been any change? Is there any abuse going on? Because obviously we need to think about things like physical abuse, sexual abuse in any age group. And these are all things that can contribute to things like depression. Now, on the more severe end of the spectrum, so we are looking at things like paranoid schizophrenia. You're looking at things like a substance misuse disorder or addictions. In teenage children, these, you start looking at the parents may say, my child is behaving in an odd manner. The child is hearing voices, is being quite paranoid, looking over their shoulder, being quite suspicious. That's on the more severe end of the spectrum. So these are signs of more kind of severe mental illness, but at the same time need very early detection in order to have a good outcome.
Yeah.
I've given you at least 2 or 3 scenarios.
Yes. So that's what I wanted to, I mean, obviously it's too huge a subject for us to give everything, but you've given quite clear ones as to, I gave the idea of, okay, autism, which is maybe actually easier, not easier to accept, but that's what we may expect. But if you're now saying, actually a 5-year-old could be depressed, a teenage girl who we think maybe is just reacting to hormones might have something more than sort of a hormonal
and that's why we always have to explore.
Yeah.
And that's why we have an assessment. The GP will have the preliminary assessment, and then he would refer to us, and we would do a whole comprehensive assessment, look at what's happening at school, what's happening in the family, take a family history, find out if there's any past mental health history, you know, do a holistic and comprehensive assessment, and then just to narrow down or narrow in on exactly what the diagnosis is. And sometimes, you know, I'm not really I always tell families, we're not really hung up on diagnosis. We're more, as the child and adolescent mental health services, we're more kind of concerned about the symptoms and treatment of the symptoms, and also support for the family. That is really, really important, because a lot of these mental health difficulties stem from difficulties within the family itself. And so we're very careful not to pathologize a child for what actually is a family problem.
Yeah. So what you're saying is, if we explore early, we can have intervention. If we're not just sitting with the diagnosis as this is it, my child is doomed, work out with service, you know, yourself, the nurses, how to best to help the child, support the family. Then we get very good outcomes at the end of it.
Yes.
Okay. I'm going to ask both of you a question. How do parents actually react to some of these diagnoses? You know, let's even leave it with something like depression. Yeah, something not too big.
Yeah.
Not that it's not big, but because I know if you give somebody a diagnosis of autism, they're probably panicking that my child is, you know, has this thing forever. But we know it operates on a spectrum. And then if or even telling a parent that their child might have schizophrenia, might have borderline personalities, these are big things. How do parents manage to ingest, you know, these diagnoses? Do you want to go first, Yetty, or Yetty, you go first because you get to give them the big news.
Yeah. Okay. Yeah. So unfortunately, I get to give them the big news, and in the sense that you know, we've done the assessment, they come into the consultation room, and then I tell them, you know, this is it, these are the symptoms, these are the issues, and this is what I believe that your child has. So let's look at something common like depression. Now, most families, by the time they've come through the assessment process, a lot of them are already kind of expecting that that's what you are going to say. But then what they want to know is how what next. Most families will say, you know, what next, you know, and really for young people, children and young people, I must stress for the benefit of the listeners that medication is rarely the first line of treatment. So that is the first thing that parents are kind of worried about. So does it mean that the child will be needing medication now? And I have to kind of explain to them, obviously, it's not the first line of treatment. We need to look at other things. Mainly, we focus more on the talking therapies. So we tell them, you know, you're going to have, you know, a number of sessions of talking therapy. Then we'll have regular reviews. There is the possibility that if the talking therapy is not going well, or the young person is unable to engage with talking therapy, that we may look at medication. So the thing is, yes, it's one thing to give the news, but it's another thing to let the parents know that there is a light at the end of this dark tunnel. And if you carefully explain what the journey is likely to look like, and how often the child will be reviewed, and the support that the child will be given, then most families are quite comfortable knowing that you are journeying with them through that difficult time. And sometimes, they want, it may be something within the family, so they may want to know how the family is going to be supported, and then what will need to be put in place to help the family. And and sometimes they would need one or two more appointments to be able to have, and they will go home, come back again, and ask for some more clarification. Obviously, there are many components to depression, so there may be a child may be self-harming, a child may be suicidal, which then points to a more severe end of the depressive spectrum. And so a lot of interventions will then need to be put into place to support that child in terms of therapy. And obviously, if the depression is very severe, it is at that point in time we talk about medication.
If you can help us talk about how the parents are when they come to you, when their children need medication, how do you make it okay for them and okay for the child? Because not a lot of people actually like taking medication, but now this child has to take this medication. You have to in some way make the parents know that it's okay. This is going to help the child.
Okay, so I guess some of what Yetty was explaining is that the way we work in camps is very different to how work goes on in adult mental health services. Mm-hmm. In camps, we work pretty much as a multidisciplinary team. So at the point where somebody in Yetty's capacity will give that news about what medication will be prescribed when it gets to that point, mm-hmm. Which, like she previously said, keeping in mind that medication would not be the first kind of like line of treatment. We would have offered the family, explored the talking therapy bit. But when we do get to the point where we're at the severe end of the spectrum and we feel that medication needs to come in, mm-hmm. I would, as a nurse, would equally be present for most of the appointments where that news is broken to the family.
Okay.
So say in a case where I'm present at that review and this family are on my caseload, I can then arrange another follow-up meeting with the family, because at that point in the meeting, I can already see that, be it mom or dad or carer or whichever kind of like next of kin is present at that meeting, I can already see that they're quite, anxious and apprehensive about this. So I can arrange a follow-up with them. And at that follow-up, meet with them, firstly, just to normalize those feelings, to say, it's okay that you feel this way, mm-hmm. and validate what they're feeling and offer some, reassurance around it. So I can then at that point say, look, this medication that we're talking about, how about I give you a leaflet about it so that you can go away, go and digest this, read the side effects, the contraindications, and everything you want to read up about it. And then we meet again in about a week or so so that you can then let me know how you feel. Mm-hmm. And I've had those cases where some of those families will go away. They would ring you in like 2 days to say, oh God, Liz, look, the side effect of this thing is not good. Why are you recommending this thing for my child? I don't want to take this and all that. And I've got to explain to them, depending on obviously what their diagnosis is. I've got to then say to the family member, say in a case where the mother or somebody in the family has suffered that same illness. Yeah. And, I take them back through that journey to say, this is what happened to you. This is what you went through for those number of years that you declined the medication. Now we're in the position where we're talking about a much younger person to you. Do you really want this child to go on that journey of that suffering that is unnecessary? Or do you want us to try and, nip this in the bud and have a timely response to this so that we can give this child a more positive outcome? Yeah. And if the family member then discloses to say, "Oh God, Liz, my journey was so terrible. No, I don't want this child to go through this, but I equally don't want the side effects." I can say, "Look, this is not the only medication, that we've got that's in this group of medications. Don't worry. Let's look at the other options, but at least let's start somewhere. Let's agree to at least meet in the middle and have a compromise." And also keeping in mind, sometimes you will have a combination of talking therapy and medication for some presentations. I also have a good example where we had talked about prescribing, and then I got to the point where at the second meeting with just myself and that family, I said to the mom and the young person, I said, "How about I propose as just 6 sessions for just the 3 of us, just to try and see if we can have some kind of brief solution focused work to what is going on here. And if at the end of that 6 session, we don't have, any improvement or any way forward, then we can then have another meeting with myself, yourself, and the psychiatrist, and then decide then if we want to try a medication."
Okay. But there will be in some cases, I think I'm addressing both of you, where actually medication is not an option. It's a must. Yeah? That happens. This is not a go home and think about it. This is something that must be administered to your child. How do parents react to that? That is tough. That is really.
If I may go, yes, a lot of the thing is parents, and rightly so. I would be worried if my child had to be given medication. Now, at the end of the day, you use the word "a must." I don't think in child psychiatry, there are many, there are very, very few cases where medication has to be given.
Okay.
We will still, in a larger extent, we would be needing to have the consent of the parents to be able to give medication.
Okay.
So our own responsibility is to explain to the patients why that child needs medication. In most of the cases, we need to tell them what the mode of action of the medication is. Most of them want to know how does depression present. Obviously, for your listeners, depression is caused by a brain, and so they would want to know how. For most of the young people, particularly the teenagers, they want you to explain, in more detail about this chemical imbalance. And sometimes it gets really very interesting. They ask a lot of questions. Like Liz said, they want to go home and think about it and come back. Okay. Now, there are a number of options in terms of medication. So there's not just one antidepressant. There are a number of antidepressants that have been licensed for use in that age group. So we would kind of have to explain that to them. Now, another question that most parents would ask is, how long is my child going to be on antidepressants, for example? And I always tell them, every child who comes into mental health service, particularly those who have depression, will fall into 3 boxes. So the first box will be those who would need medication for maybe 6 months to a year, and then we can wean them off gradually, and they may never need medication ever again. The second box would be those who would use it for that length of time as well, be weaned off, and be stable in the community for a number of months or years, and then something happens, like life just happens to every one of us, and they have to go back on their medication. Now, the third box, sadly, is for those who unfortunately would need to be on medication for much, much longer, and possibly into adulthood. But the thing is, I always give them the analogy. If you had asthma, if your child had asthma, if your child had sugar diabetes, and you needed insulin or you needed an inhaler for the child to survive and have enjoy their teenage years, would you have any reservations about that? And it's about explaining to them that though this is mental illness, it is just as important as physical illness. And if we feel that there should be a medication needs to be prescribed, and medication is going to make a difference in the child's life and in the outcomes, then it's something for them to go home and consider. Now, in 17 and almost 16, 17 and almost 18-year-olds, most of them have the capacity to make that decision for themselves, and we work with them and their parents to be able to arrive at a decision to start medication. And obviously, if there are side effects, then we need to look at what is the next best option for the young person.
I think when I said most, I may have been, yes, referring to that category where actually the illness is causing them to be disenabled. Yeah.
Yes. So so we spoke about talking therapy, you know, and sometimes the illness is so severe.
Yes.
And so disabling and having such a significant impact on everyday life and on family life, that child actually is not functioning. And so it will be so difficult for the child to engage in any form of talking therapy. So that is the point where you will be saying, actually, yes, talking therapy is the first line, but because the depression is so severe, we feel you should have medication first. And then when you are in a position to engage, you know, with talking therapy, then we can start talking therapy.
Okay. I want to go back to this, giving the parents the diagnosis. Is there a difference in the way a Caucasian family receives it as opposed to somebody or a family from the BAME community? Is there a different way they accept? Does the BAME family resist? And I think particularly, I'm maybe talking about people who actually have faith, you know, because sometimes when we are told things, like be given big news, the reaction is one of denial. So is there a difference in how they all process, because this is something real, how, you know, when they're told this thing that their child is suffering some form of medical illness, whether it's on a low level or something more, how do they react differently? Or do you see that there isn't much difference between somebody who is from the BAME community and has faith, or versus somebody else? What are your thoughts on that, Elizabeth? Or Liz, sorry.
I think it depends a lot about the awareness, regardless of which side of this you are. So if I want to come at this from somebody from the African side of this, from the side that you and I are from, a lot of what I would hear from parents will be, you know, Liz, you already know the stigma around this, the discrimination around this, you know, our community, they will stop talking to me and stop talking to my child. And those sort of things will always come up. And, you know, especially, you know, if you've given them, you know, a diagnosis of, you know, kind of like a clinical depression or something towards that, and they're like, you know, no, you know, we don't want this to happen in our family. This is going to be unheard of and things like that. And then you've got to start to slowly work with them. Just like Yetty has said, you start to unpick some of this with them to say, look, you know, okay, say, Mom, you have quite debilitating diabetes or arthritis or something that's, you know, impinging on your quality of life, and that's not making you have a life worth living, you know. So you have to look at, as I always say, mental and physical health as so, inextricably linked.
Yes.
That, you have to explain it from that angle.
You have to break it down.
Yeah, break it down.
Break it down.
To say, look, this is, it's a dosage thing. Just as you as mom cannot discontinue, the medication that your doctor has prescribed, because when you discontinue it halfway against medical advice, you feel much worse.
Mm-hmm.
So think about that pain and that struggle for this young person that's, still under that age of 18, So let's work together. There are communities that, we can tap into that will help you be able to, reassure you and start to do some of the work around the awareness in your immediate environment, be it your nuclear family or your extended family.
Mm-hmm.
It's just about you being able to break things down in the way that they understand. And then sometimes I go as far as saying to some of, I'm trying hard not to use this vain word.
I know what
it's creating quite a drama out there.
Yeah.
But what I try and also do is to say to them that, look, there is a very thin line between sanity and insanity.
Mm-hmm.
So a timely response for this young person, for us to be able to give this person a chance of a positive outcome and a positive life, that timely response is needed. Tell me who in the family, in your immediate family or nuclear family, you want me to sit with. Do you want me to sit with you all as a family so that we can unpick some of this? And so I give them that option as the nurse involved in this case. And you soon find that once these families start to build that gradual rapport with you, and they can feel that empathy and compassion is coming from you, they start to trust you and start to, let you in to what's going on for them.
Yetty, what's your view on
yes? So I totally concur with all that Liz has said, and there's something about journeying with the family. So this is just the joy of child and adolescent psychiatry, that you have the opportunity to journey with the family. And we look after children from 5 to 18. Yeah. So, it's about not just giving the diagnosis, not just telling them what the child has and what the child needs, but actually supporting them as they go through the journey.
Yeah.
Now, yes, every family that I meet, there's denial, which is normal with every news, anything to do with negative news. There's the initial denial. And so it's about we are trained as CAMS clinicians. It's part of our training to give bad news and to respond to families' concerns and also to support them. But one thing I want to say, yes, people from the from some ethnicities may struggle more with accepting the diagnosis. But ultimately, if they know that you are there for them, if they know that you will journey with them throughout the illness, if they know that there is hope at the end, then, like Liz said, they will trust you. And to be honest with you, the families that are keen to work with the clinicians, attend appointments, ask questions, are those that are compliant, are the families that have the positive outcomes. So I don't really, like Liz said, I really don't want to kind of differentiate between one ethnicity and the next. This is the family, this is the child who's in crisis. And yes, we know that some ethnicities may struggle because of this issue of stigma. But at the same time, if you break it down for them, like Liz explained, and they know that they will be supported. And most importantly, if they see me as a member of their own community, that also helps them to trust me.
Yeah. Okay. I think where I was going was actually a lot of the denial and the stigma that goes around with mental health.
Yes.
And how can we actually challenge, which is what you both of you do very well at work, which is actually making the families feel safe, coming alongside them and saying, you're not alone.
Yes.
It's going to get better. I challenge people all the time. You look after your physical health. You need to look after your mental health. So what you're saying is this child is going to be better, even in some cases where we are not sure what the outcome will be long term. But for now, I'm here with you. I will explain it to you. And really, I think sometimes if people sat back and looked within their family, they would notice maybe an uncle and auntie years ago who behaved oddly. They were ostracized. I think because we always think that when people have mental illness or are unwell mentally for a little bit, they end up locked up, and this is the only life this person is going to have. But what both of you are sharing is quite important and powerful in the way that actually it's good when they see somebody who looks like them when they come in the door, and that you treat every family like a family, regardless of color.
Yes.
Regardless of where they're coming from, you're treating them like, actually, this could be somebody I know. So I haven't met you before, but I've met you today, and I'm going to be with you on your journey, which is very important because, as I said, we talk about big news and bad news. And I think one of the things that I'm trying to bring across is to let people know who might be in this situation that it's okay. Some people actually hear these things and run away and don't go back. Yeah, I know we live in a country where, because a child is involved, you will get the medical people making sure that the child gets the help. But if the parents are resisting, then it doesn't work for the child as well as it could work. Yeah. So I think that's why I'm asking all the questions that I'm asking, so that people can know, actually, it's okay. Being diagnosed with something like that isn't the end of the world. How do you think faith impacts your work and impacts the families who come in? Because I would imagine that if you said something to a child, parents, let me not say about a child, their first reaction, like we would say, I'm going to say, it's not my portion in Jesus' name. But this is something real. It's something that needs to be dealt with. One of I say in the intro is that we have to confront our challenge. So this is a challenge sitting in front of this family, and they have to confront it. So how does faith impact? How does faith add to, the work that you do? Who wants to go?
Okay.
You go first.
Okay. Now, I am a woman of faith. I am a woman of faith myself. So I understand where people are coming from when it comes to mental illness and faith. But the point I want to make tonight is the fact that you have a mental illness should not, the fact that you have a faith does not exclude you from having a mental illness. The fact that you pray, the fact that you fast does not exclude you from having a mental illness. Your faith does not necessarily make you immune to mental illness. This is life, and life happens. Your faith just helps you, strengthens you through whatever journey and whatever ball that life throws at you. Your faith just helps to keep you strong and focused as you go through that journey. So your faith shouldn't impede on your treatment or your acceptance of the mental illness. And the thing is, a lot of time, the churches are not, I don't know how to put it without being funny.
Yeah, no, you're not being funny.
Yes.
What I want it to be is to be factual, or at least
Yes,
from
you
your
see, yes.
experience.
The churches and the church, the pastors stand and in front of the church, and they give the impression that mental illness is a form of demonization.
Yeah.
It's and you mustn't go to the psychiatrist. Once you start taking medication, it means that you no longer have faith in God, and it means that you no longer trust God, and you are putting your trust in the doctors. Now, people are looking for a miracle. A miracle may be you go to your GP, the GP may does a timely referral. You are seen very quickly by myself or by any of my colleagues. You are given medication, and you respond very quickly, and you go back to school or you go back to work. That is a miracle in itself.
Yeah.
So that is a miracle in itself. So the thing is, like I said, somebody interviewed me some months ago, and I said, church goers, I want to call them church goers, will readily accept a diagnosis, accept treatment, and comply with treatment if they have the backing of their pastor, if they have the backing of the church. So if they know that actually I've discussed this case with my pastor, and my pastor has, encouraged me to seek psychiatric help, and I know that if I go back to church on Sunday, the pastor is going to ask me if I've taken my medication, if I've seen the psychiatrist, if I've attended my therapy appointments. So if the members of the church know that they have the support of the church, they have the support of the pastor, that the pastor is journeying with them through that difficult time, if the family know that the pastor is journeying with them, praying with them as they go along that difficult journey, then we will have better outcomes. Because what we are seeing now is we are seeing 18 to 25-year-olds. Now, I want to talk about the 18 to 25s. The reason why I want to talk about 18 to 25s, even though I'm not active, even though as a child and adolescent psychiatrist, I only work up to age 18. But 18 to 25 is a very vulnerable age. And a lot of young people are presenting with severe mental illness between the ages of 18 to 25. And when you try to unpick this just doesn't happen at 18. They've been having these difficulties from as early as age 10. And because there hasn't been any early intervention, no diagnosis, no treatment, no therapy, no intervention, what we are dealing with is a chronic and severe enduring mental illness. And a lot of these young people are not able to hold a job. Most of them haven't finished university. Most of them are having difficulties with their relationships. And when you unpick it and you look at their background, sadly, it's from the ethnic minorities. And that's because that's because they're kind of focused on this stigma. Even within the church, there's a lot of stigma, and it is really sad that we are having to deal with quite negative outcomes in our young adults, just because they haven't had the help that they needed at the time it was needed.
Thank you.
Can I just add to that?
Yes, I was going to go to you.
Yeah. So I completely concur with everything that Yetty has said about this 18 to 25 age group. Now, going back to the kind of like 0 to 18 that we currently work with, as we know, when I am working in a professional capacity, then of course those boundaries are there, and I've got my code of conduct to work to. But I also then get consultations from parents outside work. So this is the bit, Lydia, that you're referring to about, where religion and faith comes into this.
Yeah.
So in that capacity, I would say to these parents, because I'm a parent myself, I would say, the Bible tells us that God has not given us the spirit of fear, but of power, of love, and of a sound mind. So therefore, if there is such a thing as a sound mind that is promised us, there is also an unsound mind. Yeah? And also the fact that, this same Bible also says that God didn't tell us that we would not go through the wilderness, but that when we go through it, he will be there for us. You always sometimes have to slowly unpick some of these things, and so that then people are able to understand it. Because Yetty is right. We're seeing more and more presentations that should really have had timely responses. And when you start to talk to some of these families about this, they would mention, some sister in the church or the pastor noticed that there was something, or I went to confide in the pastor, and the pastor said, no, you can't talk about it. Let's just pray. Let's anoint the child and this sort of things. And by the time they're doing all that, time is going, because time is of the essence.
Yes.
So, whatever is going on for that child, especially for a lot of, our young people for that age of 18-25, where there's different things going on. There is the clinical depression. There is the exacerbation with the drug-induced psychosis, because a lot of our young ones are going to uni, mixing with the wrong crowds and those sort of things, and the peer pressure. And then they're now delving into things that they shouldn't be doing, which is then, unfortunately, having an impact on both their mental and physical well-being. And when these parents come and talk to you about this thing, and they start to unpick some of these things, and you're asking them, what's been going on before? Did you just notice this? And then some parents are saying to you, oh, no, the child had an episode some time ago, but when I went to speak to the pastor, they said, let's pray about it. They said, we go to GP and things like that. So these are some of the things that we're finding.
Yeah, and what I think I think the two of you have really struck the chord about one of the reasons why I agreed to have these type of conversations, for us to have really difficult conversations around what goes on in not every church. I don't want it to say that it's every church, but what we are seeing as a result of things that were not managed well. And if somebody goes to their doctor and says their pastor and says they have a lump, they would ask them, go to your GP, see what is going to go on, and they will pray alongside that person if they get a diagnosis that is, for example, cancer. And they will pray with them right up to the end, and if that's the end of their journey, everybody will come to church and they will say, oh yes, it was the end of their journey. But if they're diagnosed with something like mental health, then we abdicate and somehow give it all to the devil, and the doctors, the nurses, and even people like myself who are counselors. I hear people say, I can't go to a counselor because they're going to put something in my mind. And I'm like, no, that's not what happens when people come. Like the person is sitting there with some magical thing they're going to put on you, but we choose actually to abdicate responsibility for ourselves and give it to who we deem is an authority figure, who is the pastor, who then gives us this advice, and then we take it, and further down the line, it's detrimental to our well-being, because our mental health, just as we said, like our mental health needs to be looked after. And the sooner we look after that, the better life is going to be. There are times that I have been stressed. I have felt depressed. I think most people go through those moments. But we find a way to manage. If you don't manage by prayer, you manage by walking, or you manage by doing something. And a lot of people actually do take antidepressants. I know people take sleeping tablets, for example, to sleep. But it's just they're taking it without, a piece of paper saying that you're suffering mental health.
LCBN television broadcasts 24/7 on UK Freeview Channel 271, Roku TV, Amazon Fire TV, Android TV, Apple TV, Google TV, See Love World, lcdntv.com, lifecomtv.com.